Everybody's video and audio will be muted throughout the seminar. We shall unmute participants on an individual basis during the Q&A session. Right. Our title today is A Tried and Tested Simple Approach to Fast Scanning, Image Acquisition in Congenital Cardiac MRI. In this, we present a step-by-step guide on how to plan, execute, and complete congenital cardiac MRI scans in a timely manner while still producing high-quality diagnostic images, no matter how complex the anatomy or the level of expertise of the radiographer. Now, housekeeping first. What we will cover today. Now, first thing we'll cover is planning both black and white blood localizers. 2, how to differentiate between left and right. We will use systemic and pulmonic rather than left to right, and for good reason. Left anatomy is not always what you would expect from the left, and likewise for the right when it comes to congenital imaging. 3, imaging the systemic circulation, true FISP, that's true fast imaging with steady state precession, cines, and phase contrast flows. 4, imaging of the pulmonic circulation, true FISP cines, and phase contrast flows. 5, 3-dimensional navigated non-contrast true FISP angiogram. Now, there is a copious amount of material and volumes of literature out there on cardiac MRI. As such, I must state that we will endeavor to cover as much of this in the numerous seminars that we will be going to hold over the next few months. In this vein, I must reiterate that each seminar will touch specifically on the subject matter at hand. Specifically on the subject matter of hand, I must reiterate. Following on from this seminar will not cover the following. Today's seminar will not cover the following: patient preparation, including the process of deciding what patient-specific techniques to use, the ECG for cardiac MRI, sequence setup, sequence optimization, respiratory triggering, navigating, breath hold, free breathing techniques, etc., post-processing. Well, we'll do a little of it at the end of the seminar, but it's not in detail. Rest assured, everything that one needs to run a highly successful cardiac MRI list will be covered in this and succeeding seminars. We will start from the very beginning, cover all the basics, and gradually progress to the more complex material over the next few months. This particular seminar is a general guide to start with. Lastly, before we start, at the end of the seminar, we would like to take some group pictures for LinkedIn. If you are willing to participate in this, we will ask you to turn your video on at the end. We will not, I repeat, we will not take any pictures of anybody who does not wish to be involved with this. Now, I have to let everyone know also that the meeting is being recorded today. Let's begin. Now, multiplane localizers. I know people might say, oh, what's the point of going through multiplane localizers? But they do actually have a good reason for doing, and sometimes you may need to do 2 of them. I must stress that everything that you do on planning sequences must have some sort of technical significance on your output images, i.e., it shouldn't just be a case of going through the motions or just following protocol. Your approach must be structured, must be systematic, sorry, mind the pun, systematic, and as with everything, good preparation leads to better outcomes. In that vein, we shall approach this seminar in a somewhat structured manner. I will first describe and give a brief explanation of the forthcoming sequence, and then we will proceed to watch actual planning Camtasia videos from real everyday scanning, with accompanying commentary from myself. Now, all that housekeeping is out of the way. Let's get on with it and move on to the multiplane localizers. Now, I mentioned multiplane localizers in the plural because you may have to do two. I tend to always do two. Why do we need a second one? And where should we place the slices? The why first. The first multiplanar localizer is not always at isocenter due to how the radiographer or technician has centered the patient. And why is this detrimental? Well, it would mean that the patient table constantly moves during the scan, especially if you do not do a second one at isocenter. And of course, you would have to constantly reposition your manual shim box or adjustment volume. And where should you place the slices for the second localizer? Well, you'd want the slices to show you the region of interest, i.e. the heart, in all three orthogonal planes, in such a way that you can adequately plan your next sequences. Now, let's proceed and go through the practical aspects of planning. So, in this box, we have your original multiplane localizer that comes on when you start the scan. Notice that the signal on these is not so high. They're just where we've centered it. Signal is not that high because the anterior coils have not been selected on this particular one. I have done this deliberately, as some people in some centers would see this sort of thing on their first scan. Now, today's seminar, I must state, is based on a Siemens Solar 1.5T scanner. I'll just change that for a second. Now, the first thing that we will do is move our table to the center of the region of interest. So hence the yellow line here. And then after we move that to the region of interest, we then plan our slices, which I shall show you shortly, such that our slices are in the center of the region of interest. Now, in this particular case, I have moved the slices down to where your ventricle will be, and I've also moved them in all planes. Now, I should state that these lines here, or these rectangles, represent the slices. I have actually hidden the slices so that you can see the anatomy. So this one represents my sagittal slice planning. This one represents my axial slice planning, and this one represents my coronal slice planning. And the idea is such that we get a view that will show us in a high signal our heart in the axial, coronal, and sagittal image, and also show our outflow tracts going upwards. Let's proceed. Now, at this point, you do not need to actually do a manual shim. We're still doing just the planning localizers. And I have to remind you that this is prospectively gated for this, although you shouldn't really spend too much time on this. It seems like we have because we're going through the explanation, but when scanning, you won't spend that much time doing this. So in the box there, we have the resultant images, and then we move on to our 2, 4, and short axis localizers. Now, there's much debate about doing these here. Some people think it's a waste of time doing these 2, 4, and short axis localizers. Some people might know them as vertical long axis, horizontal long axis, and short axis. Now, these will be single shot true FISP, also known as white bloods. Now, back to the debate, the 2, 4, and short axis localizers. As I was saying, much debate about doing these. Some people believe that they're a waste of time. We actually think that they're very useful because they will allow you to plan in advance much more than you would be able to, and it saves on dead time. That way you can continue your scan and save on time. Anyway, let's get on to it. So this is your resultant second localizer. Now, in Siemens, we have a perpendicular tool, which of course, for those that work on Philips and GE, you do not have it. So you'll have to plan everything manually. Now, in today's seminar, I'm not going to go through the operation of the perpendicular tool, but we'll go through it in a future seminar because it's rather misunderstood at the best of times. But today's seminar, we'll just presume that everyone understands it. Anyway, so our resultant sagittal, coronal, and axial images, which have loaded into our graphic segments. These are our graphic segments. And then we have our stem segments, which load on the sides. We've got our coil positions here, our spine posterior coil, and our anterior body coil. Now, we'll proceed. So first of all, we just plan our two-chamber localizer. Now, I should state, because I'm sure people will be aware that on this particular patient, they do not see a septum here. I have deliberately chosen a single ventricle patient who's had a Fontan procedure here, in order for everyone else to be able to plan using, no matter how complex the anatomy is, we will demonstrate how you can plan this. We shall shift back to that. Okay, so sorry about that. So imagine that you have a septum in this region here. What you would do is go parallel to the septum and perpendicular to the mitral valve, and then you just click your perpendicular. Now, when you do that, your slices automatically align on the other imaging planes. Now, again, if on Siemens or GE, you'll have to manually move them up to there. And then once you've done that, all you will need to do is then capture your cycle as always, and then run the sequence. And then I have preset these such that when this one comes, it will populate the first graphic segment here, and then we shall start to plan our true FISP short axis single shot localizer. Now, this should be just 2-second acquisitions. We shall skip that. And this is the resultant image that you get for your two-chamber localizer. Some people will be thinking, oh, that doesn't look like a two-chamber. Well, I repeat, this was a Fontan circulation patient, hence why you see the outflow tract here. But let's imagine that wasn't there and you had a closed myocardium. You'd have your left atria and then your mitral valve plane here and your ventricle here. Now, as you would normally plan your short axis slices, we will plan the first one from above the mitral valve and the last one just above the apex. In this case, I will do 5 slices and I will angle it to the mitral valve. And then again, use the perpendicular tool. Once you use the perpendicular tool, this automatically aligns to that because it's going perpendicular to the original plane, which came this way, that we planned to. This slice here was in the plane that is going this way. So perpendicularly on this slice will go 90 degrees to that. Now, in normal anatomy, the idea is to have your first slice going through your atrial appendage, and then your second or third slice through the outflow tract. That way, when you plan your 4-chamber, you can avoid the outflow tract. So again, we capture slice and we proceed. Then our 4-chamber, we will just use our 2-chamber again, single shot, go perpendicular again to the mitral valve, perpendicular on that. And then once the short axis localizer populates that bit, we angle it as you normally would, angle downwards towards the apex. And after this runs, our 4-chamber localizer will then populate the middle graphic segment, which we shall see shortly. Again, capture cycle prospectively gated. And again, these are just 2 seconds long. Now, here's your four-chamber. Imagine you had a septum. The septum would run straight down the middle, but again, single ventricle patient, so no septum. At this point, I will stop and talk about this green box here. Now, this green box here represents our manual shim volume or adjustment volume as it is known on Siemens. Now, at this point is where I start to set it up. My advice is to use, or when you pre-program your sequences, to use copy preferences where that shim copies. Now, these sevens here, these numbers that you see here, are my copy preferences. And what I've set these up is to copy the adjustment volume. So once I set it up on this sequence here, on the Haste sequence, everything else will copy and I do not need to change it, and I can then close my shim. Word of advice, do not copy it for all the sequences that you're going to use, especially when doing congenital cardiac MRI, because you're going to have, one, so many sequences, more than the usual that you'd normally use in your normal sort of cardiomyopathy scans. And if you copy for everything, your scanner will take time doing those copy references. And once you try to do something else whilst it's still doing that, it could crash the reconstructing system or the imaging system. So what you'd rather do is do them in batches. So my trick is I do my copy reference for the systemic circulation, and then I do my copy reference for the pulmonic circulation, and then copy reference for any special sequences, like if I do a 3D true FISP, 4D flow, or a twist, that will have a separate copy reference. So you will end up with 2 or 3 batches, but it means you only have to set it up 3 times. However, something else I should say when I say you only have to set it up 3 times. When you set it up, especially if you do not have any sort of metal artifact in the form of sternal wires or aortic valves, and if you don't have any sort of extraneous flows or fast flows where you'll get artifact, using the same sharp, small shim should usually work throughout your scan. But we'll get to that in a second. So let's move on to our next slide. The Haste. So Haste, dark blood. Haste is a Siemens acronym standing for half Fourier acquisition single shot table spin echo. That's Siemens. But on GE, you would know it as a single shot fast spin echo. And on Philips, you would know it as a single shot table spin echo. What is this sequence useful for? 1, evaluation of the whole cardiac and chest anatomy. And 2, assessment of tissue properties, i.e. T2 properties, water content, inflammation. It's also good for visualization of anatomy where there is the presence of metal implants. Now, let's get on to the planning of the Haste. So, first we will set up our shim. So what I tend to do with the shim is I use those localizers and I just copy the localizer from the short axis. I'll just pause there for a second. Note that when I copied that localizer, these then just got straight into position. It's because these 3 images are all perpendicular to each other in some form. So copying that one, these then align to that. Now, the key thing, contrary to popular belief, is using a very tight shim that does not cover, say, lungs or infringe into metal artifact in the form of sternal wires as we have here, or into the stomach or into bony regions. It works. People think that they have to open their shim. You do not have to. So we will keep it sharp. We'll move on. So I'll just cover the left usually. In this case, we won't say left because we've got no septum, but usually just putting it over the left side of the heart is usually adequate for this. You can take at least 20, 30 seconds setting up this shim, because having a good shim actually means that the rest of your scan is nicely in plane. Now, these first Haste sequences will be in the axial plane. It's represented as a box, but there are slices coming from superior to inferior. And I've got 46 slices here, 6 millimeters thick. And we proceed. Now, the Haste sequence is also prospectively gated. I shall get onto that in a short bit. One thing I need to mention here, which tends to be an issue, especially with Siemens operations, is people tend to capture cycle here and go without first looking at this bit here. The trouble is your ECG is not always as regular as in the RR not shifting, which is your RR here. So you have to check when you capture cycle that the acquisition window does not infringe into the R peak. Otherwise, that will give you blurry images and it will also increase the acquisition time of the sequence. So once you capture, check that it's nicely captured and there's a little gap between the end of the acquisition window and the next R peak. If not, then just reduce your TR and your acquisition window to make it fit perfectly. Now, once I click go, I want you to look at these 7s here. You will see a blue circle that will just be going around here, which is telling you that the copy preferences are taking effect. And it's free breathing, by the way. This is not breath hold, it's free breathing. So as you can see here, I've shifted this back as after the capture. And we click go, and then the copy preferences are taking effect here. We wait till the copy preference take effect. And once they've taken effect, the next sequence then opens. Now, as I said earlier on, don't do too many, do them in batches. You saw the effect, how long it took. It took about 10 to 15 seconds. If you had done it many more, it would take longer and you wouldn't be able to then proceed to the next. Now, our next sequence, the true fist single shot white blood. So I copy slices and center of slice groups rather than, well, I copy center of slice group rather than slices only because this sequence has got a negative distance factor. By that, I mean that the sequences are actually overlapping. The images are actually overlapping. And once you have those images overlapping, combined with your other parameters, it means you have a very sharp sequence rather than blurry sequences, which I shall demonstrate in a second. So capture cycle as always. Shift the trigger delay back a little bit. Keep it in diastole. And then acquisition, then take the lip off. And there's our Haste sequence coming in. And then our shim. Right. So we proceed with the white blood center slice groups. And I shall stop there for a second. I'll touch a little bit more on the overlapping slices. Let me just go into it. When you are viewing the slices, you won't necessarily actually be able to tell that they're overlapping. However, when planning, in this particular case, I've got a distance factor of minus 20%. And the 20%, if you are not a Siemens user, is 20% of the slice thickness here. In this particular case, our slice thickness is 6, which means that you have a negative 1.2 distance factor. So they're overlapping by 1.2 millimeters. Hence why we have 56 slices here instead of the 46 that we copied from the Haste sequence. And you shall see the results shortly. I'll just skip that to the results. We've covered this bit here. We won't cover it again. Here's your acquisition. within diastole, the regular and not going into the or encroaching into the R peak here. And here's your white blood axial. Very sharp. You can even delineate and see your valve planes and everything else. Now, the beauty with having sharp white blood images, we've got only the axial one here. We shall be doing the coronal and sagittal ones next, is that you can actually follow the anatomy as you are paging through the sequences. And that way, that is how you would actually determine which is systemic and which is pulmonic circulation and any other bits that should or shouldn't be there. Now, coronal. It's the same as the white blood axial. It's true FISP or Fiesta, as it's called in GE, or balanced FFE in Philips. Same process, prospectively triggered. We won't go through this again. And also overlapping slices as before. And the resultant images. Now, something else I have deliberately done on this particular sequence, as you can see, our shim is still quite the small shim here. But we have artifact up here in the ascending aorta and arch. The reason that we have artifact up here is because of the sternal wire's proximity to the arch, as the patient's chest is going in closer to the actual arch, which I shall show you on the sagittal. Now, in such a case, we would then change our shim in such a way that it actually eliminates that artifact. You do not need to do what you call this. It will come back to me, sorry. We'll change the shim to cover this. It will come back to me. I've just forgotten what I wanted to say there. But I shall show you something. You're probably wondering what this is. This is the Fontan conduit. As I stated before, this is a single ventricle patient that has had a Fontan procedure. Hence why you are seeing that bit here that shouldn't be there. But we will go through that artifact and how you get through it, rid of it shortly. However, even with that artifact there, you can see how sharp the image is. You can actually see bits like your aortic valve there, your mitral valve leaflets coming in there, and then, of course, all other bits here. That's your conduit there. And then we'll just continue that. So that's me changing the shim now. I'll stop there. Now, note that when you change the shim like this, you then have to check it on your other planes, your axial and coronal plane, and shift the anterior back bit of that shim so that it doesn't go over the sternal wires. If that shim goes over the sternal wires, you will have more than one peak and it will not be effective. But we shall look at that later when we get rid of this artifact here. And then the sagittal one. I will not bother going through the sagittal bit. The planning is the same. It's also a Fiesta, a white blood, but I'll just put it up there. As you can see here with our Haste sequence there, our coronal one that we did, original multiplane localizer, and then we capture cycle as we did before. And then our coronal or sagittal comes into that box. At this point, I shall stop. Look at all those sternal wires here. The green box, our shim, is going over the sternal wires. So the idea is to bring that back so it's not over the sternal wires and bring it as far back as possible just to cover the actual anatomy that you are scanning. Now, this box here that I'm planning is our coronal oblique stack. This is a cine true FISP sequence, but I shall go back to it at a later stage when we're doing the pulmonic side. So I will skip that bit for now. 4-chamber true FISP cine. Now, normally you would actually do one slice of your 4-chamber if you're doing your cardiomyopathies or your standard cardiac MRI. But in congenital, you'll find that at the best of times, you may have to do stacks. In this particular case, we're going to do a stack with 10 slices. But first, your true FISP. So this is where we need to set our new block of copy preferences. And this block of copy preferences will simply be for the systemic flow. Now, we tend to run our true FISP cine sequences at 50 calculated phases, something that we'll cover in future seminars where we are talking about optimization of sequences. First thing we will do is copy the shim from the Haste sequence, and then we'll take it from there. Let's view the video. So what we have here in the boxes, so copy the adjust volume first, and adjust volume is in place now. So we have our original 4-chamber localizer, our short axis localizer, and then we'll get our 2-chamber localizer in there. The green box is as before, our shim, the white blocks represent our slices. So what we simply do is take our slices, and then we copy the image position of our 4-chamber localizer, and already in plane. So it avoids the need to keep angling your slices or anything, doing those original 4, 2, and short axis localizers. We angle it. If we must change the position, we can do that. But because we had those localizers from the very beginning, we do not need to do that. This is retrospectively gated. And I have to state, because you are doing so many slices and so many planes, this is the reason that most places that do congenital end up scanning their patients for between an hour and a half to about 2 hours, sometimes even more. Now, at Transform MR, we've cut our imaging time, even for the more complex studies, to between 45 minutes and an hour, sometimes even less. How do you do that other than, preparing as we did before by doing those localizers and obviously optimize sequences? You have to keep your acquisition time for each sequence very short. And even without the use of sort of the AI or any of the acceleration techniques, that are in like compressed sense and deep resolve, we can get your image acquisition for each cine sequence to about 4 seconds. And how do you do that? You do that by altering your parameters, something again we will cover in future seminars on sequence optimization. But I'll just touch a little bit on it here. So if you note here that I have used a field of view of 240, most people will be thinking, that's too low, you'll lose signal or this and that. But it's all relative. It's a relative signal. You then have to go and change other parameters to get that signal back. Now, what this does means that you then have less phase encoding steps to cover. And when you have less phase encoding steps also, without all that unnecessary extra coverage, it means that you cut your imaging time down. Now, we run 2 slices per breath hold only because we've managed to cut this down to 4 or 5 seconds. So you see here I've got 10 slices, but 5 breath holds. It means that 2 slices run in 10 or 11 seconds at most. We can even cut them down further. And before I can see some people might be thinking, that will impact on image quality. No, if you've optimized the sequence, it won't impact on image quality, as you shall see in the forthcoming images from this. So we shall skip to that. So again, with all three original localizers here, when we click go, the copy parameters for the adjustment volumes copy, as you can see with the blue thing here. And then you can see a new section here for the pulmonic side. Then we'll skip to the images. And here we go, we start. Now, the next question might be, why are we doing a stack of 4 chambers? Well, being a Fontan patient, the idea is if we cover the whole ventricle with our stack, we can actually see and map out our valves and any sort of left out septums. We can see our Fontan conduit and we can see it in plane. And if we need to, we can also see its relationship to the atria. And if there's any fenestrations too, we can see it on that. It hits a number of stones, a number of birds with one stone. And it also shows you your pulmonary veins, which you can then use. Let's just go back, see that here, your pulmonary veins there, for you to plan your pulmonary flows. But there are many tricks for it. I didn't show you the fenestration over here, but there'll be a better view. See the fenestration here? There'll be a better view for that also later on. And that is why we do a stack. So that's our 4-chamber localizer. Sorry, 4-chamber cine view. So we started planning our 2-chamber. We did it by just first copying our 2-chamber localizer, which is here. Let's just skip to that. And I won't bother doing, I'll just skip straight to the output image for our 2-chamber. And here's our 2-chamber. So despite that being 5-second acquisition, I want you to see the quality of it. You can see very, very clear contrast to noise ratio between the blood pool and myocardium. And you can see your valve leaflets very well indeed, with no artifact also or shimming artifact, despite the multiple sternal wires and other inputs for artifact. Now, whilst that's running, as I said, no dead time, we can start planning our short axis through FISP cines. So now that we have our 4-chamber in here, and then our short axis localizer, and then our 2-chamber cine, which we shall put in here. First copy the image position as you would. Again, 240 field of view. Oh, on the 240 field of view, people might be thinking, what if you have a big patient or a very big patient? We still use 240 field of view and we use oversampling. Now, I know it's controversial because I've come in before, gone into different departments and various applications work where people have told me that they shouldn't be using oversampling. And I've asked why. I haven't really been given a particular answer to it. And when people have tried to give me an answer, we've actually debunked the reason for that answer to say that it doesn't work because we haven't found it having any detriment or effect to the quality of your image or to the output for your cardiologist or radiologist to actually do their functional tests. So it doesn't matter. And the way we've done this also is we've set this, or we preset this, something that you should be able to do after we've gone through other seminars on sequence optimization, sequence setup, where you preset your sequences and your protocols such that you won't have to alter these, or your team won't have to alter these when they're in the normal everyday scanning. So they're already preset with all these bits. Now, our short axis. So with our short axis, for this particular case, so sometimes not only in Fontan circulations, you may find that you need to do a block that not only starts from just above your mitral valve, but that includes both atria and all ventricles in. And for the reason for that is when you do it in this particular case, you can then get the Fontan conduit in plane, almost like a true sagittal view of the Fontan conduit and its relationship also to the rest of the anatomy there. it doesn't matter because people might say, oh, won't that make life difficult for the cardiologist or radiologist when they're reporting? No, with the reporting software here, it will pick up where you've got myocardium when it does your contours. So it won't really affect it once it gets to that point. So we're using our 4-chamber cine, and we'll get our 2-chamber cine also. And we're changing the shim for this. And the reason we're changing the shim, we're using the bigger shim, is because, as I said, we want to include the Fontan conduit. And we know that at the top of the Fontan conduit and in the aortic arch, we had artifact earlier on. So we'll use the bigger shim for this one. As always, as you're planning, angle parallel to your mitral valve and is perpendicular to a septum, but in this case, there's no septum. Just imagine an imaginary septum going through the middle there. And then we'll just skip to an image, and then I'll just stop that image there. So at this point, I want you to look at the quality of the image, despite having the sternal wires that you have here. And you look at mitral valve leaflets here, aortic valve, the myocardium, blood pool, even trabecular, and actual contrast to noise ratio between the blood pool and myocardium, and obviously your spatial resolution also. Look at the quality of that despite using a 240 field of view. And whilst that's running, you can then start planning your other bits also using the images that you've got. For example, here I started planning my twist, which is my angiogram. Not that you always have to do a twist. And then I can plan my 4D4 and 3D nerve too. By the time I do my pulmonic circulation, all these will be ready to go, and it just saves on time. You might end up finding yourself just sitting there, twiddling your thumbs, waiting for it just to get through it. But that's it. I think we need a break. Right. Welcome back. We shall move on now to the systemic outflow tract. Now, systemic rather than 3-chamber as you normally would. But before I continue on that, earlier on there was something I mentioned which I said you didn't need to do, but said would come back. I'd forgotten the name. It's a frequency scout. Now, at 1.5 Tesla, you never need to do a frequency scout, really. But at 3T, yes, 1.5, I've never had to use a frequency scout. As long as your frequency is set up, your adjustment volume is set up appropriately, you should be okay without a frequency scout. Now, let's get into the planning for the systemic outflow tract. So now that we have our 2-chamber short axis and 4-chamber cine images, because we used a coronal, which we've put in the middle there, we planned a coronal outflow, and we planned a sagittal, original localizers. We can just use that coronal on its own initially and just perpendicular to that. It's unlike when you plan on a normal cardiac MRI where you'd use your short axis, align it to the outflow tract, then align it either to go into the atria and ventricle. In this case, if you just use your coronal image and just put it straight up there, if you wish to, you can check and align it also to your sagittal oblique, but the problem is the anatomy is not in the place where it should be. So if you just perpendicular on that, and if you're on Philips or GE, if you just put it, align it straight to that and do the same on your short axis and just let it go through the outflow tract, that should get you a good systemic outflow. Let's play that. So again, it's retrospective. We do not use any arrhythmia rejection on this because it's fairly regular. And arrhythmia rejection is something that we will be covering in the future, by the way. And this is your short axis coming through. If you recall, we did many slices that covered all the way from outside the atria, all the way to below the apex. And the reason for that is so that it can show you your Fontan conduit and your outflow tract in a different plane. The shim is the same one that we used to remove that, that artifact. And then this is just me repeating the same process of the copy preferences. Now, I shall skip this a little bit. And there's your resultant image from the first outflow tract. So that is probably what you would call your reverse or coronal outflow tract. It doesn't really matter which way you do it. This is the easier way to do it when doing such anatomies, because you do not have a normal 3-chamber. Because in normal cardiac MRI, you'd plan it initially as a 3-chamber, and then you'd plan this next image as your LVOT. That's what most people would do. But it doesn't matter if you do it the other way around, and it's easier done this way. So you can see the quality of it also with your ventricle and your aortic valve leaflets there up into your aorta, your sinotubular junction here. And you can actually see some of the coronaries coming off there. And you can see the valve opening quite nicely. So all you will need to do with your reverse one, that would result in something similar to your 3-chamber, is just place it bang on in the middle of that and perpendicular on it. Let's just skip to that. And this is how you would do it. Straight down the middle. Oh, something else I need to mention on this is phase encoding direction. Very, very important. Now, what tends to happen is people get a lot of artifact from some of their images in the phase encoding direction because they've set the phase encoding wrong. Now, as a rule of thumb, not always, as a rule of thumb, you would rather put your phase encoding direction in the direction of flow, especially where you have high flow. So you can see here we've got our phase encoding direction on head to foot and with an oversampling factor of 80%. Now, people think, oh, head to foot 80%, which means that you've got 40% this way, 40% that way. Will that not actually wrap? No, it won't, because your coil selection is on auto coil select, which means that above this here, there's no signal coming from there and no signal coming from here. So that should give you a nice clear image without any wraparound artifact in this. But if you're on Philips, you'll just click no phase rep if on Philips. Or you could do manual. I actually prefer, rather than just using the no phase rep on GE, I actually prefer to actually do it manually and define how much phase rep I would do. And you can actually, on Philips, you can actually put different amounts of phase reps either side, head or foot. On Siemens, you can't do that. It's just a percentage. Then it puts half of it on either side. So straight up it. And then look at that view there. And this is that starting to plan aortic valve. And then this is the resultant image. You could call this your 3-chamber. In effect, it is 3 chambers, really, because you've got your ventricle, part of your atria, and then you've got here your outflow tract going up and your aortic valve view here. Now, the aortic valve. Now, we at transform MR, do it slightly different. We prefer to use flash, which is fast low angle shot for our valve view cines. Something again we will cover in detail in another seminar, rather than true FISP. We believe it gives us images that of higher spatial resolution and higher contrast to noise, believe it or not, than our true FISP ones. We can actually see, well, technically, it might not be correct to say it that way from a technical point, but when you actually visualize it, you can actually visualize the valve leaflets and the blood pool much clearer than you can on the true FISP images. I may as well also talk about the 2D phase contrast flow that we then plan using the same images. There's much debate about this because some people say you shouldn't plan it at the valve plane and you should actually plan it at the sinotubular junction or in the ascending aorta. But we found that, and some of the literature does state this, that measurement in the ascending aorta tends to lead to underestimation of forward flow, particularly in patients with bicuspid aortic valves or other valve pathology. But it's all about the complex flow patterns that emerge when you've got a closed system or a narrow system where you start getting vertexes in there, which means that if you have a vertex, you can actually measure the phase from those particles, which means it becomes inaccurate, whereas if you do it right at the plane, it's more accurate than in the ascending aorta. But of course, in this day and age, we've got 4D flow, which takes care of all that. For those without 4D flow licenses, I mean, in the past, some places would do valve planimetry, where instead of just doing one view, they would do a 3-chamber in plane flow so that they could see where the peak velocity is, and then they would do a number of slices, but with different velocity encodings of Venks, which actually took much longer to do. But I guess it was advisable in the days before 4D flow, but these days with 4D flow, just do a 4D flow and that's it. Let's get into the planning. So we usually do 3 slices, with the first slice planned just below the valve leaflet attachments here. And then I'll take this opportunity to actually show you another way of planning a dedicated shim for the aortic valve, especially where you've got very high flow in the aortic valve. So this is our systemic outflow, the second one. Again, you can see the quality of that, despite it being 240 field of view. So angle to the valve, you can see one of the valve leaflets here. You can see a bit of AR here. And then with our shim, just copy the image position and make this shim as tight as possible on both your outflow tract views. Now, you would then do a manual shim, and don't forget to also select shim with body coil if you are to do this. And again, it's a flash or gradient echo. Don't spend too long planning it like this or aligning it. I've just done it for the purposes of this seminar. So I'll just skip to the resultant images. And here are the resultant images here. So now, something I wanted to show you on this, as I was stating about the flash, not only do you have good delineation of the valve leaflets on this, even on one that should have been a pulmonary valve, but obviously been Fontan, it's not there. But you can also see that fenestration coming in from the Fontan conduit into the atria. So I'll just play that and you can see that clearly. See the flow coming from the fenestration and then the valve leaflets here with such a small shim like this. And you can see our leaflets there, our tricuspid aortic valve, and our fenestration there. And I'm setting up my vent here at 150. I don't expect it to be higher than that. And the beauty with this image, you can also then plan a flow or vent, a flow, phase contrast flow of the fenestration if required. And then shortly, we shall get our phase contrast flow image. And there we go. Now the phase contrast flow image also demonstrating our AR going or backwards flow. And there we go. Now, sagittal oblique aorta. This doesn't differ much from how you would normally plan it using your axial white blood, our coronal white blood, and our sagittal. Most people would use the 3-point plan tool here and just put it in ascending aorta, arch, and descending aorta. I just do it manually. I just page through on our white blood localizers up to my arch. I align it to the arch, and on the coronal, I just align it to the descending aorta. And then the resulting images will be here for arch. Again, same shim, no more artifact up here. Loads of sternal wires, but no artifact coming here. And then we can use this to actually plan our descending aorta flow, which you can see here. Again, with the flows, tip for doing the flows, always center on the vessel of interest. Don't off center off that. It affects your accuracy. Always center in the middle of the vessel of interest. If you must, use oversampling, but with my sequences, we always use oversampling anyway. Now, the pulmonic flow. Now, so with our pulmonic, in this case, it won't be your usual right ventricular outflow tract or right ventricular outflow tract, coronal, and your branches. In this case, because we do not have the RVOT, instead we've got the Fontan conjugate. So we call it pulmonic or Fontan true fists, but we'll also do our branch pulmonary, so our left pulmonary artery, our right pulmonary artery, and then we'll do the flows on that. Now, let's get on to the planning. So what we did is first we planned a Glen using the 3-point plan 2. Now, the Glen, some might wonder, I'm loath to go into it deep because we're going to do a specific seminar on imaging the Fontan circulation. But I'll just briefly go into it. When you have this particular procedure, it's in 3 steps. So normally you will have your Norwood procedure first, and then you'd have your Glen procedure just to connect so that flow goes into the pulmonary straight from SVC. And then to complete it off is then when you put in your Fontan conduit, that then connects that PA down to the IVC. So when you're scanning Fontans, people want to see that that Glen is still functional quite well. So what we would do in this particular case is we'd use our white blood axial images, our coronal oblique that we had cine, and what we'd do is we'd look at the SVC there with 3-point plan on there, first image on there, second image on what would be your bifurcation, although it's not really a bifurcation, then third image into the RPA here, because what we have was a right-sided Glen on this one. You can get a bi-directional Glen, but in this case, we're the right-sided one. And then your 3-point plan should do it. You can manually plan also if you want, by just aligning it to that and making sure it's going through the SVC. And the beauty is we do have 3-point planning also on Philips and GE, so we should be okay with that. And then the resultant imaging from that should be, let's skip to it. And you're starting to see the image here coming into your gland, and then the next one, and there you go. So now you've got that there. We know it's a well-functioning gland, and we've got our RPA coming down this way. And then once you've done that, because we can see that our RPA is already there, we won't bother doing an RPA. We'll just skip straight to the left pulmonary artery. And again, you just use the white blood localizer from the before, and this is showing the importance of those white bloods, initial white bloods. You just angle it to your LPA and click perpendicular again. Or if you are not on Philips, you just angle it to that and adjust it accordingly on your other planes. You're not on Siemens, sorry. And then we just skip to that. Now, there's something that we call the seagull view, which just shows both your RPA and LPA in one view, almost like a seagull's wings. But I won't bother going into that at this point. We'll leave that for the seminar that is going to focus solely on our Fontan. But this is how it would look once it is done. Then SVC and IVC flows. Again, because of those white blood localizers, all you need is your white blood axial localizer, your sagittal and coronal. And remember to be perpendicular to the vessel that you are measuring the flow to, and to be centered on the vessel. Now, the thing to do with these is just get your white blood axial, copy the vessel, image position. In this case, I'm too low, so I'll go up to the top for FCC, and just take care not to catch any branches. So I've shown you the SVC there, copy that image position. Then I'll bring this is my gland view. I can align it there so it's perpendicular, but I'm also going to bring in my Sag white blood into there, and then I'll angle it such that it's perpendicular to the vessel in the sagittal plane. Let's just bring that Sag in there, and there you go. And then SVC, and just make it perpendicular there, avoiding any branches, and that should give you a good SVC flow. And don't forget to set the venk, of course. And it's retrospectively gated again, as you would. And here's your SVC4. Nice circular SVC. And then likewise, when we do the IVC, use the white blood axial, copy the image position, then go to the Fontan conjugate, align it to the IVC, and again on the sagittal, perpendicular to it, so you have a nice round thing. And don't forget to avoid getting into any hepatic vessels. Then we can skip that. And there's your IVC flow. Now, people are probably thinking, oh, there was some aliasing. The aliasing was in the descending aorta, and this particular one wasn't specific for descending aorta. It was for IVC. Hence, we had our velocity at 100 rather than 150. We're almost at the end, so don't despair. And then we've got our twist, which is your time-resolved angiography with interleaved stochastic trajectories. Yeah, I know it's quite a long bit to take in. But with this twist, right, the value of this twist is your temporal resolution, very high temporal resolution. And they say it's of low spatial resolution, but you can make it a reasonable temporal resolution. Why is that important? You want to follow, especially with these complex anatomies, as you can see on the twist here. You want to be able to look at the blood supply in each plane with a minimum time in between so that you can split it at the end. When you do your normal angiogram, you're either doing it for your systemic circulation and timing it also to then catch the return for your pulmonic circulation. But in between these two circulations, you are missing a lot of data. Worse when you're doing babies. Now, the beauty with the twist, and we do it free breathing, by the way, there's no need to breath hold it, provided that you train your patient at the beginning of the scan to gentle breathe. Again, something that we'll be covering in future seminars on patient preparation. Your twist for babies, the temporal resolution should be sub 1 second, so just under a second at most. But for your adults, depending on their heart rate or output, it can be 2.5 seconds. In this particular case, our temporal resolution was 2.3 seconds. Now, I've been to places where they were doing babies, and I looked at the temporal resolution and they were wondering why their test wasn't working. And that was set at 5 seconds, which meant that they lost a lot of information. And because of that, you were just getting saturation and they couldn't then split it. For example, if with this particular one, which I shall show you, if I have a temporal resolution of 2 seconds, it means that I can split my anatomies on each. I can look at my branches, I can look at my Fontan conduit on its own without the rest of the other bits on it. I can look at my systemic circulation on its own. But let me show you. So this is my MIP reconstruction from my twist, but as you can see, it's coming in. So you can literally separate, and I'll slow that down a little bit. Let's go back. So let's go back. So in this case here, I've got my RPA, LPA. I'm not quite seeing the glen on this one. Then, and I saw the glen on the one just before that. And you're seeing the glen coming in here. Then, now you're seeing your pulmonary veins here. And when we do our reconstruction, I'll show you that you can actually separate these and do a proper reconstruction of each bit. Then now we're seeing our aorta, so our systemic flow, and our descending aorta, our ascending aorta, your subclavians, pulmonary veins, very well. Good thing also with these, if you've got PAPVDs, that's your partial anomalous pulmonary vein drainage, or your TAPVDs, you can actually separate these. And remember, again, this is free breathing. And now we're going for the return flow. So now we're seeing your IVC coming up into your Fontan conduit again. So again, beautiful view of my conduit, of my glen here. And this is on the return flow. You can see that here. Beautiful view of it. And then let's skip to the reconstructions. Again, the 3D for this, right, is not complicated at all on Siemens. It's just a few clicks and you're in it. So I'm in this box here in the 3D view. And then I'll just stop there. Here, you are seeing your phases and you are seeing your time here from your phase, like at 23 seconds, at 25.4, and then at 27.6, which tells us that our temporal resolution was 2.3 seconds, as you can see here. So you can pick any of these and load into 3D and do a reconstruction of that. So I've picked my phase number 9 on that, which was at 41 seconds after contrast administration. And then I'll load it into my 3D. And the beauty with this, right, is you can use this reconstruction and bring it back into your planning page and use it to plan, for example, flows for your pulmonary veins, only because over the years doing congenital cardiac MRI, I know for a fact that one of the things that people struggle to plan is pulmonary vein flows. Now, with views like this, where you can clearly see your pulmonary veins there and there, you can just bring that back into the imaging page, and then you can plan from there. Now, there's something else that I wanted to show you that I didn't mention during the scan. What is that there? And again, you can bring things out. You can zoom in and out, or you can fade in and out and remove certain anatomy and bring other anatomy in. This is all in your Siemens 3D page. And we are done. Questions and answers. If anyone wants, you can raise your hand and we can unmute you and you can ask a question. Or if there were questions that were coming in during, my colleague can pass the questions to me and we'll take it from there. Any questions, anyone?